Balvinder Rana to enhance our knowledge on this.
Thank you, Chair. Thank you, Organizing Committee, Dr. Bhandari, Dr. Pushpender, Dr. Vishwas, and other members for giving me the opportunity to be here today. So after the examination in foot and ankle, the next step is the radiology. But to speak a bit about the foot and ankle surgery, I don't know how we look at foot and ankle surgeons. About a couple of years back, not far behind, people used to look at us from like this. I mean, we don't understand what we do. Are we men from outer space? Another thing I want to say, in orthopedics, जो लोग पीछे बैठते हैं, they become joint replacement surgeons, all of you guys. And the first benchers who think more become foot and ankle surgeons. It doesn't mean anything, just a joke, don't take it otherwise, but it's a food for thought. But coming to the topic at hand, there are various modalities to assess our patients after clinical examination, starting from X-rays, ultrasound, MRIs, CTs, and bone scans, depending on conditions that we are looking to diagnose. Coming to X-rays, we can have a problem in the foot. When we do a foot X-ray, we can have problem in the ankle when we do an ankle X-ray. We cannot overstress the importance of weight-bearing X-rays in foot and ankle. When we write, as a foot and ankle surgeon, when I write an ankle for the foot, it's always, by habit, it's always a weight-bearing foot, AP and lateral, always, without fail, if it is not an acute trauma, obviously. This is the way you take a foot weight-bearing X-rays. If you do not take a weight-bearing X-rays, the projections are not proper, and a lot of things can be missed. So always in a cold condition, take a weight-bearing X-ray, anterior-posterior and lateral view of the foot, and this is how it will look like. And there are a number of things which we can pick up on a weight-bearing AP and lateral X-rays. The third X-ray obviously is an oblique of the foot. Depending on the condition that we want to diagnose, we will take it. Now, these are the simple ways, simple X-rays of the foot, but there are some special views in the foot we need sometimes, and this is one of the Harris-Beath views, the axial view of the calcaneus, which can be taken to see a stentaculum process fractures, calcaneus fractures, as well as subtalar collisions. In talus neck fractures, what we fail to take is a canale view, which shows the neck in profile the way it is. It is shown here. The pointer is not working, but if you do not take a canale view in a neck fracture in the operation theater, you will not be able to see whether your fixation is anatomic or not. Another view is a Broaden's view in the operation theater for calcaneal fractures. The foot is rotated internally 40 degrees and the beam is directed at various angles from caudate to caphlete, looking at various aspects of the posterior facet, and that's the fracture. And that is how you do a Broaden's view in the OT for calcaneal fracture. Unless you did that, we're not able to, this is an axial view, I'm sorry, this is not a Broaden's view, so there is a mistake. This is an axial view in the calcaneal fracture. Along with the Broaden's, you must take an axial when you are operating a calcaneus fracture. The other special views in the foot is a sesamoid view. A sesamoiditis can be diagnosed, as a sesamoid fracture can be diagnosed. We can take it in a prone position or we can take it in a supine position with the foot, with the ankle dorsiflexed. Some of the foot conditions, these are the various views, but to give you some examples of importance of weight bearing. So a non-weight bearing X-ray in a patient, and then as you bear weight in a suspected Lisfranc, you can see significant amount of instability there. That's a flex sign in one of our physiotherapists. A slight widening of the bases of the first and the second metatarsals with a bone, speck of bone there. This is an unstable Lisfranc and it requires internal fixation. And when this is associated with a plantar ecchymosis, this is a sure sign of an unstable Lisfranc injury, and this needs to be operated. There are some other important things that we can look at depending on the conditions we are diagnosing. Various angles in the foot, in hallux valgus, hallux interphalangeal angle, then the hallux valgus angle. We all know how to do this. The intermetatarsal angle, there are divisions or classifications of hallux valgus based on these angles into mild, moderate, and severe, and your osteotomies can be planned according to the severity of these angles. Another important thing in hallux valgus is the congruence of the distal metatarsal articular surface. Now remember that most of the majority of deformities in the hallux valgus are incongruent, which means there is a slight subluxation of the first MTP joint. But you can have a situation where the joint is actually congruent, which means the distal metatarsal articular angle is abnormal. So if you understand that, if you do not understand that, there will be some percentage of hallux valgus which will fail if they are congruent joints. This is a congruent hallux valgus, which means the articular surface of the metatarsal is scooped to one side. It is not lying straight at angle at 90 degrees to the axis of the metatarsal. It is on one side, and the joint is absolutely congruent and parallel. If we do an osteotomy here, which is usually done for other incongruent hallux valgus, it is bound to fail. So you need to correct the articular inclination there. A very different kind of hallux valgus, especially in juvenile population, it requires a different kind of treatment. Now, that is about hallux valgus. Flat foot, a number of angles are described. In the AP weight-bearing views, talocalcaneal angles. This is the long axis of the talus in green, both in the AP and in the lateral views. And in the red, you see the long axis of the calcaneus, both in the AP and the lateral views. So the talocalcaneal angle is wide in flat foot patients. Then the talar first metatarsal, this is the long axis of the first metatarsal, both in the AP as well as in the lateral view. The talus axis and the first metatarsal axis are practically parallel in normal people, while they will be deviating in cases of flat foot. Calcaneal pitch, Simon lines, other indicators of the severity of flat foot we need to look at when we are examining patients of flat foot. Another important in AP view in flat foot is the talonavicular uncoverage, normal side, and you see the subluxation of the navicular and uncoverage of the talar head on the medial side. So the percentage of this uncoverage and the correction of it is a prediction of prognosis after surgery. That's again important. There is an importance of measuring these angles on the flat foot and defining what is the deformity, because different angles will tell you a different part of the deformity, and your surgery will then be addressed to correct those angles and deformities. So every flat foot is not same. So you have to define where is the maximum deformity, and then as per your angles, and then there are procedures which will correct that specific deformity based on this table. So it is important to look at the flat foot X-rays judiciously to decide. So that's the broadness. We have already discussed that. Coming to the ankle, that was all about foot. We all know, we are not going to details into the what is normal AP and normal mortis. I think we all know that. What are the measurements of the tibiofibular clear space, the tibiofibular overlap, parallelity of the distal tibial and the talus articular surface. All of that stuff we know. But we should know that the lateral view, the fibula has to be in the posterior 1/3 of the tibia, and just a part of the tibia should be seen. Unless we see that, it's an oblique view and we can be misled. The mortis view again, there are different parameters for tibiofibular clear space, tibiofibular overlap, and the talocrural angle telling you the shortening of the fibula there. So all of these things we must be aware which exist. Then there are some stress X-rays. Talus tilt stress test for lateral ankle instability, and we have an anterior draw test for anterior posterior instability. So we do not routinely recommend these in patients even with instabilities, because our clinical judgment actually relates to more to surgical interventions than a positivity of the stress test. That's a suspected Lisfranc. Apart from the weight bearing, there is a manual possible stress when you rotate the foot at the level of the first metatarsal, and then you do another X-ray and you see the instability in a suspected Lisfranc fracture. Ultrasound has an advantage. That's about X-rays, and about ultrasound has an advantage of being dynamic, but it is operator dependent, and tendons can be very well visualized, especially the peroneus brevis tears, the tendoachilles, and the peroneal instability and tendoachilles rupture. Especially if you're treating them conservatively, you can plantar flex the ankle and look at the gap of the tendoachilles closing in an ultrasound, and there is apposition of the ends, then we can treat them conservatively. It can also pick up calcaneonavicular coalitions, and then obviously the MRI. All the tendons and ligaments around the ankle can be visualized clearly with the help of an MRI. Here's an example of an FHL tenosynovitis. This is an example of Achilles tendinitis on the back of the ankle, and split peroneus brevis tendon, all of these conditions, and subluxated peroneus brevis lying on the lateral surface of the fibula there. All of these can be picked up, and the ligaments obviously. That's an intact ATFL. And the section of the MRI where you comment on the ATFL is when you look at the talus as a snowman shape. When you look at the talus, that section of the MRI which is showing this shape of the talus, that is the section where you will comment on the ATFL, and that is where you do not see an ATFL in this case. Is a complete tear. Other indications of MRI would be stress fractures, osteomyelitis, and Morton's neuroma, especially the tarsal tunnel. There is a space occupying lesion, a ganglion cyst, and these are the big Morton's neuroma. OCD talus is another indication which will define the size, and then finally the CT. A number of applications. For sake of time, I have omitted a lot of slides from here, but we all know the indications of CT, especially in fractures. 3D reconstructions are really helpful. So I'll rest my case here. Bone scans sometimes are helpful. So summary is that depending on the patient and your condition, you will do the X-rays, but weight bearing is the stress that I make. I always take a weight bearing view. Thank you very much.
Thank you, sir.